And then for the purposes of the minutes for next time, could the people on the phone just quickly share your name? We have a 215 number. I'm not hearing anything. So I'll move on to the 410 number that ends in an 02. And then a 410 number that ends in an 08. Haven't heard anything yet from any of these folks. So just let me know, I guess, afterwards. You shoot me an email if you want me to reflect your name in the minutes for this meeting. Okay, so let's go ahead and get started. Welcome everybody to the 5th session of the Value Plan Work Group for 2026 value plans. Our first order of business is to vote on the minutes from our last meeting, the August 6th meeting. Does anyone have any feedback on those minutes?
So Becca, hearing no feedback, I move to approve the minutes of the August 6, 2024 Value Plan Work Group as presented.
Second.
Okay, thanks Evelyn and David. The minutes are approved. So the agenda for today is pretty straightforward. We've already voted on the minutes. I'm going to do the second draft, or the revised draft of the 2025 or 2026 value plan designs, and then we will take a vote. So I had previously mentioned possibly bringing a presentation to you on some more 2024 value plan data, but we determined it would complicate the voting process since we don't have enough years of data to draw conclusions to the point where it would make sense to use that to inform 2026 plans. So we have decided instead to focus on finalizing the recommendation for 2026 today, and then if people have questions about value plan performance so far, we can follow up with more information about that later, but just didn't want to muddy the waters too much. So just a little transparency there. So yeah, I'm excited to show you the hopefully final round of designs for 2026. It's pretty similar to what you've seen before, but let's get into it. So since the last designs you saw, so previously in the 3 lowest AV plans, the bronze, the silver, base silver, and silver 73, the actuaries had reduced that to the copay for labs to $45 from $80 in each of those plans. We received carrier feedback on that first round of design saying if we do that, we're not going to be able to stay there. Those carriers said that the AVs will not be in range if we go that low on those copays. So what we did was raise the bronze lab copay back up a little bit to $55, which is still a lot lower than $80. So also we filled in those additional standardized cost sharing services in at the bottom of the matrix of the plan designs. So those are things that we can't plug into the AV calculator, but still want to standardize across the plans. Part of that is pediatric dental services, and we had received feedback in 2025 that pediatric dental major services, there are 2 categories of them, and that they should be aligned in terms of cost sharing. They should have the same cost sharing. The other 2 separate categories. So that's classes 3 and 4. And so, yeah, based on that feedback, first, we had set them both at 20%, but the feedback was that the industry standard is that they should both be 50%. So that's the kind of version we're presenting to you today. So I'm going to go over each of these separately. So just to review, the Silver 73 plan, so the cost sharing reductions for Silver plan to make it 73% AV. We've reduced the lab copay to $45. You can just see that comparison to the 2025 plan on this slide here. The base Silver, we did the same thing. So 80 to 45. And then for the Bronze plan, you can see 80 to 55 highlighted cell there, the new lab cost sharing. And then the additional standardized service categories here. And this is, kind of small, but you can see that for class 3 and class 4, it's at 50% now. And so that's aligned across those two categories. And we also had a typo where we had in the Bronze plan here, just flagging, it should, if for any post deductible coverage in the Bronze plan, since we've designed it to have the deductible and the maximum out of pocket be the same, after the deductible is hit, there should be no cost sharing for any of those services. So because those were not in blue, they had a co-insurance there, but it should actually be not applicable. So just flagging that. So this is the summary of the designs. Does anyone have any comments, questions, things you'd like to discuss before we go ahead and vote? Justin.
Thanks, Becca. I just curious to have a little bit more background on the change with respect to the pediatric dental. I'm hearing and I understand the interest in aligning the co-insurance for the major services, but I'm curious what the rationale. So I guess it previously it had been at 20% for class 3 for several years. Is that right? So I'm curious what the rationale for having it at that level previously was. So if we're changing it now, I'm curious what we might be giving up given where it had stood.
Yeah, that's a fair question. My understanding is that it is, just because major services are a costly service category, that having it at 50% is just more commensurate with the cost to provide that care overall. And, in other states, like California and other states as well, that's the cost sharing for class 3. So we'd kind of been an outlier, and I think, we were trying to keep everything as low as possible. But I mean, this is up for discussion. I mean, any other thoughts? And, those who feel strongly about it being 50%, feel free to chime in. But we did get a lot of feedback that they should both be 50%.
Yeah, I guess I'm certainly curious to hear from others. I guess one reaction I have to that is the fact that class may be expensive. I have no reason to doubt that, but to me that's not inherently a reason to raise cost sharing on consumers. I mean, that's sort of some of this gets to be pretty circular when we start to go down that road, right? So I'm curious if there's any other. I'm curious what other folks think.
Yeah, does someone who commented about that want to weigh in? Let's see who we have on the call. Allison, yes.
Sure, I can speak to that. Really, one of the principles of benefit design is to base cost sharing according to value, price and value of a service. So think of it in terms of PCP versus specialist or generic versus specialty drug. It would be the same approach as pediatric dental. And if you look at, commercial coverage, exchange standardized benefits across the board, you'll see a trend of lower cost sharing for preventive and diagnostic and higher cost sharing for major services. So like Becca said, for example, the California standardized benefit design has a higher current co-insurance amount for major services. If you look at the DC standardized benefits, they have higher copays for major services. So it's just aligning the level of service with the consumer cost share.
Sure. You know, you mentioned DC with co-payments, and here we have a system that's entirely co-insurance. Is there, you know, is there something to that to think about?
Yeah, I think we were trying to in the other service categories, to the extent that we could, go with co-pays instead of co-insurance, because obviously it's easier for consumers to plan and expected costs based on that when they're comparing plans. Dental services, there are so many very specific types of services that 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 consumers may receive. And in DC, they had the kind of resources to go through and figure out what the copay should be for each one of those. But that is not something that we have been able to do. And I mean, it would be nice if we could, but that is not something that we've been able to do. David.
Yeah, I would just say that the dental world is quite different in terms of payment than the medical world. In medical world, often payment can be based on conditions, managing conditions and things like that. In the dental world, everything is procedure based. So in my mind, co-insurance does make sense in the dental world, specifically because I don't even think they have diagnostic codes in the dental world. They just do, here's what we did, and this is what we charge for it. So I think, Becca, what you were saying is we would have to have, like, a list of 50, 100 different copays, versus the co-insurance route just covers it broadly. And it's just a very different, in terms of billing, it's very different than the medical side of things.
I'm curious, does DC actually have 50 or 100 co-payments listed out for these services?
I can look and circulate DC's materials. That's
okay. I mean, I'm just trying to understand, because it has, I mean, to the extent that this is a somewhat substantial shift for consumers off of what has been the case for several years. I'm just trying to understand more how this might actually work for folks. And I understand it doesn't feed into AV, and so I certainly have a less understanding of some of the dynamics on the dental side, and certainly when it comes to some of the other changes here with respect to dental coverage. But I'm just trying to understand more what we're doing here.
Yeah, that's fair.
I also have a question about, for the carriers, if it affects the ability to find dentists to participate in network, because I know where we are, it's really difficult to find in-network dental providers, even for children. So I'm just curious if this change reflects in that area, or if I'm just off base. I'm not sure, but I know, is this meant to help keep providers in network? Maybe nothing to do with it.
Matt.
Matt, you're on mute.
I think it's a separate conversation, David. I know that, all the dental carriers are, adhering to the network adequacy laws that are on the books as of now. And I don't think this would have an impact on building or distilling a network, so to say.
Okay.
I mean, this can certainly be a conversation if people don't feel ready. I mean, I guess just it's going to be up to the vote for this kind of change this year. Perhaps we shift it to next year, and it's up to you all. We could vote to keep the cost sharing for pediatric dental the same this year and revisit it again next year. It's really up to you guys. Happy to hear more discussion on it. Richard.
So just to be clear, this increase doesn't have anything to do with keeping the cost of the plan within the range of the actuarial value de minimis?
I think that's a question for carriers. How much does, because I mean, although we can't put these services into the actuarial value calculator, my understanding is that it all affects AV. And so by raising this, we do have more wiggle room to do other things. So I'm wondering, carriers, is that right?
Yeah, so I'm curious to know whether or not that's the case, because it was, I'm pretty sure everybody on here is familiar with the case of DeMonte Driver, right, who passed away in 2007 due to tooth abscesses. So, you know, access to major dental services for young people is a hot topic, at least in this state. So I'm curious to hear whether or not the increase from 20% to 50% has anything to do with AV or anything like that.
So, Becca, it is my understanding that everything sort of fits into the AV in this space. And Richard, as somebody who was in Annapolis and sort of worked through the tragedy that was Diamante Driver and all the reaction that was taken by a lot of different agencies to try to address that crisis, I think that it is definitely at the forefront of every discussion around the dental space. At the MIA, at the MHCC, at the exchange, at the General Assembly. Everybody is very much aware that we just sort of need to keep that tragedy in mind as we look to expand access. And I think that Maryland has done a really good job of expanding access, especially in the pediatric space since that tragedy. But I think there's more to do. But we have seen record enrollment in the dental space on the exchange year over year. Becca, please correct me if I'm wrong, but it's not abnormal for people to have a dental benefit now. And it was strange over a decade ago. So we are making progress. And I think that one of the reasons that folks are encountering and buying and getting dental benefits is because the premiums are inexpensive. And we want people to have those preventative services to make sure that we're doing the pay now, pay later thing. You know, we pay small amount now, get the preventive coverage so you don't have to pay a lot when you're a lot sicker later. And I think that we will continue to make progress. But I don't think that this, and then remember, Richard, this is just the value plans, right? We have an entire marketplace besides just these particular products that some people are going to be purchasing. But I think that there's much work to do, but I don't think that what Becca has laid out here and is going to upset the marketplace. And I think we might want to move forward with the proposal because I think it's a common sense, smart solution for now.
But thank you for that response. Like I said, it was just out of curiosity that I was asking to see whether or not the increase had anything to do with the AVs. But thank you for clarifying that everything influences the AV.
Joe?
Thanks, Becca. One question, did Lewis and Ellis weigh in on this for the AV calculator? Or did we work with MIA on that?
We so they developed everything. I will say that the change to the 50%, I haven't gotten their feedback on yet, but like I said, that's something that they add after they've put the kind of main grouping of services into the AV calculator. But I can definitely, talk to them more.
It may, and we have another meeting after today, correct?
Mm-hmm.
So it may be worth it to go back to them and see if we can get some opinion that we can share with the committee. It seems like there's enough discussion around this that we could have Elodie and the MIA weigh in on it as well, and then come back to this group.
Thanks, Michelle. All right, that sounds like a good plan. Does anyone have feedback on any other pieces of the plan designs? Okay. Well, thank you so much for this discussion. This has been really helpful. So my plan will be to, get some more information, bring that back to you in 2 weeks. And then I just wanted to remind everyone of the timeline. So we have one more meeting scheduled on September 3rd. And by on September 12th, we're presenting whatever this work group recommends to the Standing Advisory Committee, and on the 16th to the MHBE board. So the 3rd is our last opportunity to vote, unless we schedule ad hoc meetings. And then we'll meet again in December after or whenever the AV calculator has been released to discuss any other changes we might need to make. And then we'll bring the final designs to the board in the spring. Any other final thoughts before we wrap up today?
Yeah, Becca, I think in addition to Lewis and Ellis's perspective, I think it would be helpful to look at the other plans on the marketplace, as well as some other standardized plans in other jurisdictions. We've talked about covered California. We could also look at DC, look at some other states that have standardized plans, and just to compare how pediatric dental, the out-of-pocket cost sharing is designed across those major classes. I think that would also be helpful for the next discussion.
Thanks, Allison. Yeah, that makes sense.
And I'm happy to share, we obviously participate in other state-based exchanges, so I can send some information your way if that would be helpful.
Yeah, thank you. Yeah, and I really encourage everyone, to take a look at the designs when I send them, or the designs that I have sent. And if you have any other feedback at all, try and send that to me as soon as possible, so that in case there's any other information I need to gather, that I can incorporate that, so that everyone feels prepared, like they have the information that they need to vote at the next meeting. Great. Anything else? Okay, great. Thank you so much, everyone, for your time and your thoughts.
Thank you.
Thank you. Have a good rest of your day.
You too.